So, dear students, this is the first time a discussion on topic has been demanded by my student, which I really appreciate, because I always say if you are studying anything and not getting the answers, you can ask me anytime. I hope my voice is audible. Still, if you don't get anything that I pronounce or say, please ask me in the comment section. So, the student has said that they want to learn about the management of hypertensive emergency and the management of hypertension and stroke. But as I always say, do not jump into the last part too quickly. Start with the basics first. So, like other approaches, first of all, I would like to talk about how would you approach to a patient with hypertension. Then do the diagnosis of hypertensive urgency and emergency. Then do the management. Okay? So what is hypertension? First of all, you have to learn what is blood pressure. It is the lateral pressure exerted by the moving column of the blood while it is flowing through our vessels. Okay, so what is hypertension? When there is an elevated pressure in the arterial wall, that is called hypertension. So there is some cutoff below which we diagnose the patient is normotensive and above which we say the patient is hypertensive. So what is the cutoff for this patient? Normally it depends on different ages. With age, it is natural for the arteries to become more sclerosed and become hardened. So with age, there is a mild increase in blood pressure naturally. But the worldwide recognized cutoff for diagnosis of hypertension is systolic blood pressure more than 130 and diastolic blood pressure more than 90 mm of mercury. Okay, systolic more than 130 and diastolic more than 90 mm of mercury. So when we are measuring the blood pressure, we have to see if the patient is ideally seated. Okay, there is the arm supported by the hands of the chair. If the patient is in acute stress, the patient has climbed 6 floor stairs, say for example. If we are examining the patient in that context, we will obviously get elevated blood pressure. So the patient must be in rest, has not taken any drink, caffeinated things in last 30 minutes or 1 hour, has not done any strenuous activity, has not smoked in last 30 minutes. I have to use an appropriate sized cuff as well. Then I will measure the blood pressure. In this ideal situation, if we are finding the blood pressure is increased, can you say it is in hypertension? Okay, so no, we cannot say this is hypertension based on one single reading. At least 2 readings are advised, and best if these readings are taken in a home condition and an ambulatory blood pressure, means different settings, so that the blood pressure measurement is not influenced by any stress. Okay, so have you learned about the white coat hypertension? When the patient is consulting with the doctor for any other purpose, they are coming to the chamber and to the consultation, and they have stressed about the appointment, or they are in a long queue waiting for the doctor, or as soon as they enter in the room, seeing the doctor itself creates some stress. So in this setting, if you are getting an elevated blood pressure, it is called white coat hypertension, but not necessarily the actual hypertension. So based on one single reading, we can never diagnose hypertension. We will go for different readings. It is most likely advised if the readings are taken in both home and the ambulatory environment. Okay. Now you are persistently getting the blood pressure higher. What is the diagnosis? If the blood pressure systolic mark is between 120 to 129 mm of mercury, 120 to 129 mm of mercury, we say this is elevated blood pressure. This is elevated blood pressure. And what is hypertension? When systolic blood pressure more than 130 and diastolic blood pressure more than 80 mm of mercury. We are dividing these into 2 more stages, stage 1 and stage 2. Stage 1 means the blood pressure, systolic one, is between 130 to 139. Okay, and diastolic between 80 to 89 mm of mercury. And stage 2 hypertension, when the systolic blood pressure more than 140 mm of mercury and the diastolic blood pressure more than 90 mm of mercury. Okay, this is called stage 2 hypertension. Okay, then after diagnosing the hypertension, should you start the patient with some drug? That's all you can do? No. So before starting the drug management for hypertension, always think, is it a case of initial essential hypertension or primary hypertension, or is there any secondary pathology involved? Though mostly 90% of the cases in the old age patients, it is essential hypertension that is mainly influenced by the genetics, increasing age, family history, etc. And there is no identifiable secondary reasons found. But what if I say this patient is 30 years old, a young gentleman who has recently noticed hypertension followed by headache. He had extreme headache, so he had consulted to the pharmacy and measured in the local pharmacy. Every time blood pressure is 180 over 100 millimeter of mercury. Or patient has taken 2 or 3 medications in the last 1 month for the control of blood pressure, but the blood pressure is not being controlled at all. So this can be a clue that it is a secondary hypertension. So in any young age patient with resistant hypertension or very short history of hypertension with many target organ damage, you should always think about, is there any secondary cause involved? So what are the secondary causes that may be leading to hypertension? There are some renal causes such as chronic glomerulonephritis, chronic kidney disease, adult polycystic kidney disease, renal artery stenosis. There are some endocrine causes such as thyroid dysfunction, pheochromocytoma, Cushing syndrome, Cohn syndrome, primary hyperaldosteronism, or there may be some other secondary reasons as well, such as vessel abnormality, coarctation of aorta. So, before starting the treatment or jumping into the treatment, think if it is a primary or secondary hypertension. Okay, if I have excluded all the secondary causes, before starting the treatment, look if the patient is already taking any drug that may worsen his hypertension or that may be contributing to his hypertension, such as long-standing steroid, NSAIDs. These drugs may cause fluid retention, oral contraceptive pills. So in this case, we have to switch the drug or have to ask the patient to stop the drugs. Okay. Then we have to look if there is any evidence of target organ damage. Okay. So what are the target organs that are most commonly damaged by this uncontrolled hypertension? First of all, heart. There may be evidence of left ventricular hypertrophy. There may be ischemic heart disease. Okay. The eye. There may be changes of hypertensive retinopathy. Then renal, there may be acute renal failure or the evidence of proteinuria. Okay, so is there these signs present or not? Or in case of brain, the elevated blood pressure may also cause hypertensive encephalopathy. So you have to look if this patient has these signs of target organ damage or not. Okay, then you have to suggest some investigations. This can be just a simple case of hypertension, but this may not be also. So with hypertension, look for other comorbidities. If the patient is diabetic, look for OGTT test, okay, hemoglobin A1C. Then in case of lipids, check the serum lipid profile. As we know, atherosclerosis may be contributing factor of hypertension. If you are thinking, okay, this may be a secondary case, finding other clue, then go for CBC, complete blood count. Look if there is any anemia or if there is any polycythemia. This polycythemia may be a sign of adult polycystic kidney disease. Then look for the chest X-ray. There is an evidence of already cardiomegaly. Okay. Then we will do some renal function test, serum creatinine, urinary to look for an evidence of proteinuria. This may indicate subtle renal damage. If you are thinking this may be a case of Cohn syndrome, primary hyperaldosteronism, look for the electrolytes. We have to look for the aldosterone level. The electrolytes are suggestive of primary hyperaldosteronism. If the patient has other evidence suggestive of thyroid dysfunction, go for a TSH test. Okay, hyper and hypothyroidism both should be excluded. And then after this proteinization, also look for any vessel abnormality. Okay, in case of young patient presenting with resistant hypertension, I always say, look if there is any secondary causes present. Because if we are not finding out the main basic reason behind the hypertension, no matter what management you give, we are going to lose the patient. So, what is hypertension? Diagnose if it is hypertension accurately. Look, it is primary or secondary hypertension. Do the investigations, and before starting the treatment, know at what stage the patient is at now, with or without any target organ damage. Okay. So after doing all this, now you go to lifestyle modification and drug management of hypertension. So that's enough for today. In our next video, I will discuss about what is the lifestyle management and what is the pharmacological management of hypertension. Okay. Thank you.